that is the inspection. And in the inspection you need to examine about the uterine shape, the contour of the uterine shape is, you need to check whether it is globular, and if it is distended, and how is it distended, if it is uniformly or non-uniformly distended, you need to confirm. And contour of the uterus means whether there is presence of stria gravidarum and linear nigra that is present, and if there is any presence of scars which indicates previous surgeries or previous cesarean deliveries also. And if there is enlargement should also be noted, and if there is any scar mark that also needs to be noted, which I have already told. Coming to the next thing, that is the palpation. In palpation, the height of the uterus must correspond to the period of amenorrhea. Suppose if the height is greater than the amenorrheal period, then it might be a case of mistaken date might have been reported. Mistaken date of LMP might have been reported, or it might be a twin baby which is causing increased height compared to the amenorrhea period. And or it might be is even a dangerous cause, like a tumor might be present, or hemorrhage or polyhydramnios might be present. Sometimes the height might be lesser than the amenorrhea period, and this might be due to the mistaken date, or it might be due to the fetal growth retardation, or it might be intrauterine death of the fetus might also be taking place, or it might be due to oligohydramnios. So basically it is due to mistaken dates, or it might be due to the fetus. It might be related to fetus, or it might be related to the fluid which is going to fill the fetus. Coming to the obstetric grips, also called as the Leopold's maniers. Before going to the obstetric grips, remember that in inspection, the skin condition means that you need to verify if there is a presence of evidence of the ringworm or scabies. And yeah. Then coming to the next thing, that is the in palpation, the height of the uterus is determined by placing the ulnar border of the left hand on the uppermost level of the fundus. Remember that this palpation should be done from below upwards, because the uterus will grow from below towards the upper end, so you have to go in that direction itself. Okay, coming to the next thing, that is remember that the height can be sometimes greater than amenorrheic period, even in case of the accidental hemorrhage might have taken place. Coming to the obstetric grips now, the Leopold's manuals. Fundal grips, you should face the patient here, and you should use both the hands for this grip. Full fundal area should have to be palpated. If it is found to be breech, it will be usually felt as a broad, soft, irregular mass, and if it is cephalic, it will be felt as a small, hard, globular, and independently ballotable thing. Coming to the lateral grips, are also called as the umbilical grip. Here, you need to use both the hands while palpating for a particular side. You need to push the other side and feel for this side. For example, if you are palpating towards the right region, you have to push the left hand and feel with the right hand. If it is smoothly curved, and if there is a resistant feel and it is uniform, then it must be a back region. And for in case you find that it is back region, you need to confirm whether it is present anteriorly, transversely, or posteriorly also. Then the limbs can be confirmed by you pushing the right hand and feeling with the left hand. And it will be felt like a empty knob, like irregular parts might be felt, and that confirms it to be limbs. Coming to the next thing, that is the Pollock's grip, or also called as the third Leopold, or also called as the first pelvic grip. In this Pollock's grip, we use only one hand facing towards the patient. You need to place your ulnar border of the hand over the pubic symphysis. It's not directly. You need to feel with the index finger and the thumb. You need to first place the ulnar border of the hand on the pubic symphysis. Then you have to extend the overstretched thumb and feel for the head. Suppose if it is a transverse lie, and there won't be any presenting part usually present in the Pollock's grip. or the first pelvic rib. Coming to the second pelvic rib, this is done facing away from the patient and by using both the hands. In this, the four fingers of the both the hands should be brought from upwards, down, and then you have to feel, you have to approximate. While approximating, you can understand three things by using this second pelvic rib. That is, first is the presenting part, second is the engagement, and also you can understand the very important thing, that is the attitude. How do you determine the presenting part? You can easily determine the presenting part by feeling how it is, how it gets felt. Suppose if it is soft and independently palatable, then it must be a cephalic presentation in that way. Coming to the engagement of the head, you can confirm it by the convergence or divergence of fingers. If it gets converged, if the fingers, that is, if both the hands get converged, then it is not still engaged. Or if you can feel the occipital and sincipital folds, then you can confirm that it is not engaged. But if the fingers get no if the fingers get diverged, then the head must have got engaged there. Coming to the next thing, that is the attitude. Attitude is determined by finding the by finding the sincipital and the occipital poles of the ceph- cephalic presentation. Coming to the auscultation, the fetal heart sounds are heard by the auscultation. First, it confirms that it is a live baby. Second thing is that it can confirm about the presentation also. Suppose if the fetal heart sounds are better heard at below umbilicus, then it is a cephalic presentation. And second thing is that if it is heard around the umbilicus or above the umbilicus, it is better to diagnose that it is a breech presentation. Now, in that, in order to confirm whether it is occipito anterior or occipito lateral or occipito posterior, that is, if the occiput is lying anteriorly or if it is lying laterally or posteriorly, we should hear the fetal sound very much carefully. Suppose if it is very much in the spino-umbilical line, if it is nearer or if it is medial to the midpoint of the spino-umbilical line, it is occipito anterior. Suppose if it is lying more laterally on the spino-umbilical line, it is occipito lateral. And if it is lying towards the flank, if it is heard more much better towards the flank, then it is a occipito posterior. But that all these auscultation should be done on the occiput side, that is on the side of the back only, not on the side of the limbs. Okay. Coming to the internal examination, the diagnosis of the presentation and the position of the fetus may not be accurate by internal examination during the pregnancy when the cervix remains closed, but during the labor, you can easily feel you can easily look at the fontanelles as well as the sagittal sutures, from which you can predict much better in the internal examination. But it is not to be done during the early stages of pregnancy. Coming to the next thing, that is the ultrasonography. When is this ultrasonography used? It will be used in the following cases. First, in the primary gravida. Why should you use in primary gravida? Because the abdominal muscles are not lax here they are very much tough, and you cannot feel it properly, so you use ultrasonography in primary gravida. In obese women, due to increased distribution of fat and irregular distribution of fat, you cannot get properly the presentation and lie on all those things. And in case of excess liquor amniae also, there will be less accurate determination of all those parameters. And even in case of deeply engaged head, also called as the not fifth of head present in the abdomen, which is related to the rule of 5 or the fifth formula, then also you need to go with the ultrasonography. And in case of irritable uterus also, you need to go with that. So depending upon the contour or the contour of the woman, that is primary gravida or obese woman, and it depends upon the water covering the fetus, as well as upon the engaged head and irritable uterus. Coming to the inference you can determine by these three lines. You can just read up this, and very importantly I'll tell the extra points here is that in order to determine the presenting part, the vertex is diagnosed from the first pelvic grip. The cephalic prominence being the sinciput, remember that the cephalic prominence being the sinciput is placed on the same side towards which the limb lies. Okay, coming to the position, the occipito anterior position is diagnosed by the following criteria. First is by the inspection you can do, or you can do the palpation. In the palpation you can do the lateral grip or the second Leopold manual, and you can even confirm it through the auscultation. So let's go with the first one, that is through the inspection. Convexity of the uterine contour can tell that it might be an occipito anterior position, or by the use of the umbilical or lateral grip you can find that it is not far from the midline. Then you can confirm that that is the region of the occipito anterior position. And by auscultation, if it is more towards the medial side of the midpoint of the spino-umbilical line, then that also suggests that it is occipito anterior position. In that way, by use of the inspection, palpation and auscultation, you can determine whether it is occipito anterior position or what kind of it. Coming to the next thing, the last concept, that is the engagement of the head. When biparietal diameter of the head has passed the pelvic brim, then it is called the head is said to be engaged. If there is divergence of fingers in the second pelvic rib, then it is an engaged head. If there is convergence of the fingers in the second pelvic rib, then it is a fixed head. Remember that the engagement happens not earlier, but it will happen only at the 38th week, that is at the term pregnancy. There is or during the part of the labor. Remember that engagement is a part of the labor, so it should happen during the time of labor or during the term pregnancy only, and not before that. Remember that you can even confirm that it can be an engaged head by using by feeling for the sincipital as well as the occipital poles. If these are not felt, then the head must be engaged. It is remember that in primi gravida the engagement occurs by 38 weeks and not corroborative in clinical practice. In majority of the cases, remember that it is this usuality is only in the primary gravida cases, but in other patients, in majority of the cases, the engagement occurs in between 30 to 42 weeks, that is at term pregnancy it will be occurring, or it might even be in the first stage of labor. But remember that in case of multigravida pregnant, and the engagement occurs late in the first stage of labor, after the rupture of the membranes. After the rupture of membranes, that there will be the engagement of head in case of multipara or multigravida patients. Okay, coming to the next one, that is, however, remember that sometimes if the primary gravida head is not engaged, the causes might be, it might be a deflexed head, or it might be due to cephalopelvic disproportion, or it might be due to polyhydramnios, or it can be due to pelvic tumors. Just group these two pp, that is polyhydramnios as well as the pelvic tumors, and DC, deflexed head, and the cephalopelvic disproportion. This is related to head, and this is related to the amniotic fluid, and this one is related to a pathological condition of cancer. Remember one more important concept, that is about the fixing of the head. Engagement does not always mean that the head is fixed, because sometimes even if the head is not engaged, even if the head is not engaged, but still the head might get fixed to the ischial spines. It can get fixed while the biparietal diameter passes through it, but still we cannot call that it is engaged head. So therefore fixed head can be either it can be engaged or it cannot be engaged. Remember that engaged head is also a fixed head, and engaged head can also be a non-engaged head, can also be a fixed head. So therefore engaged head should have to be a fixed head, but a fixed head may or may not be a engaged head. That's the very important concept. important concept is that the lower pole on vaginal examination we have found that the lower pole of the unmolded head is usually at or below the level of the ischial spines. The distance between the pelvic inlet and the ischial spine is about 5 centimeter, but the distance between the biparietal plane of the unmolded head means it has not undergone any alteration in its in the shape of the head, to the vertex is about 3 centimeters. So the head if it is along the bipyramidal diameter, if the engaging diameter of the head is bipyramidal diameter, it can easily pass through. Starting with the concept of diagnosis of the pregnancy. The menarche starts from usually during the age of puberty, that is 13 years. It will start and it will terminate usually at the age of 45 years. And the youngest person to have given birth by a cesarean section was Lina Medina from Peru, and she was just 5 years and 7 months. And the oldest one was 57 years old, 57 years 4 months old. And coming to the duration of pregnancy is either it is 280 days or it is 10 calendar months or 9 not 10 calendar months, it is 9 calendar months or 10 lunar months and 7 days, or it can be 40 weeks. And the calculation will be done from the first day of the menstrual. If the calculation is done from the first day of the menstrual period, then it is called last menstrual period, then it is called as the gestational age or also called as menstrual age. And if it is done from the date of the ovulation, then it will be 266 days, and it is called as the true gestational period or also called as the fertilization age or ovulatory age. Coming to the first trimester, what are the different changes that take place during the first trimester means? So the first one is the amenorrhea, and there will be nausea and vomiting, which is also called as morning sickness, and increased frequency of menstruation, breast discomfort and fatigue. So first one, let us go with the first one, that is amenorrhea. Amenorrhea usually it is due to the simply, what does the amenorrhea? A means no, amenorrhea means menstruation, so there is no menstruation in the first trimester. What is the major cause? The major cause might be the patient might be pregnant, that's it. Or it might be, if it is proved to be some other thing, it might be due to some other causes also. Coming to the next point, remember that there might be some cyclic bleeding which is very scanty as well as short, and this will take place up to 12 weeks. Up to 12 weeks it can take place, and it should not be confused with the pathological threatened abortion. This is simply called as the placental sign due to the fixing of the trophoblast to the uterine uterine endometrium, and there is fusion of the decidua space by the decidua vera and the decidua capsularis, and this is responsible for the placental sign. So the reason for the placental sign is due to the implantation that takes place by the trophoblast to the endometrium. This is the basic point you have to remember, and it should not be confused with the pathological threatened abortion. Coming to the second symptom, that is the morning sickness. It will be varying from just nausea to loss of appetite and vomiting also. It can occur even beyond 16 weeks also, and there is no effect to the health of the health status of the woman. It in earlier pregnancies it can even cause decrease in the weight of the woman. Coming to the frequency of micturition, the frequency of the micturition becomes a troublesome one, and it will start particularly in the at the gestational age of 8 to 12 weeks. Why is this so? It is due to the pressing of the bulky uterus, or it might be due to the atrophic ureters, and due to the hypertrophy of this bladder mucosa and development of the muscles of the bladder mucosa, leading to the congestion of the bladder, and even due to the maternal osmoregulation, which gets changed due to the increased sodium levels and potassium levels, and hypervolemia, which causes the thirst and polyuria. All these conditions, if they get and they accumulate and result in the troublesome micturational symptoms. The breast discomfort, usually it is felt in primigravida only, and there is a feeling of fullness as well as pricking sensation will be seen at the 6th week, and secretion, that is the colostrum secretion, starts during the 12th week. So breast discomfort starts in the 6th week, while the colostrum secretion in the 12th week, and the last symptom will be the fatigue. These were all about the subjective signs. Now coming to the objective signs. Coming to the objective signs, the breast changes, these are much evident in dark women, um, and in the primigravida it will be evident at the gestational age of 6 to 8 weeks. There is enlargement of the breast as well as enlargement of the veins, that is engorgement of the veins, as well as there is pigmentation of the nipple and the areola region. Pigmentation of the primary areola and secondary areola are also occurring, as well as there is formation of the Montgomery's tubercles. They will become prominent, and even the axillary tail of spines becomes painful now. The colostrum will get secreted at 12th week. It will be a deep yellow colored alkaline serous fluid. Coming to the pelvic changes, the pelvic changes show many types of signs, and this is the most important thing you have to remember. And first is the Jacquemer sign, or also called as the Chadwick sign. This Jacquemer sign is due to the bluish discoloration of the anterior vaginal wall as well as the cervix at the 8th week of the pregnancy, and it is due to the excessive vascular congestion at the walls. The vaginal signs are three. The first is the Jacquemer sign, and the second is the softening of the walls. And there is also copious, non-irritating mucoid discharge, which is white in color. And this is a vaginal sign, which is physiological and not to be confused as a pathological sign. And another important sign is called as Osiander's sign. O represents for the next letter, that will be the pulse, which is represented by P. Therefore, it is the increased pulsation felt at the lateral fornices of the vagina. Coming to the cervical signs are two. That is, first is the softening of the walls, as soft as the lips of the mouth it will become, and it is called as the Goodell sign. And the Jacquemer sign, as I have already told, it is the bluish discoloration of the cervical wall due to vascular congestion. J for Jacquemer sign, or also called as the Chadwick sign. O for Osiander sign. G for Goodell sign. P for uh, the Palmer sign. U for uterine sign, and P for Piscacic sign and Hager sign. Coming to the uterine signs, it will be suggestive of the size, shape, and consistency of the uterus. At the 6th week of a pregnant uterus, it will be of the hen's egg size, and at the 8th week, it will become the shape of the size of the cricket ball, and at 12th week, it will become the size of a fetal head. Coming to the Piscacic sign, remember that Piscacic sign is talking about the firmness. P is talking about the F, that is the firmness. That is, one half of the uterus will be more firmer than the other half, and this symmetry will be restored later in the at the later stages of pregnancy. Coming to the Hager sign can be elicited at the 6th to 10th week only, and the basis of this, what is the basis of this Hager sign, is that the fundus has to make space for the bigger circumferential breach, which for which it has to be enlarged very much compared to the lower part of the body, which should be soft, and also it should be a little bit firm also. Basically, it talks about the asymmetry of the firmness as well as the size of the uterus to accommodate the different parts of the fetus. Okay, and this is elicited by the bimanual palpation. Bimanual palpation uses external as well as internal fingers. Internal fingers are the vaginal fingers, wherein two fingers of the right hand are inserted into the vagina, and which are directed towards the anterior wall, vaginal wall, and the external fingers come posterior to the uterus, and these are called as the abdominal fingers. And on approbation of these fingers, okay, on approbation I'm sorry apposition of these fingers, which is below the body of uterus, you can elicit this sign, and it becomes cup shaped uterus it becomes, okay. And this should be done with extreme care and gentleness, so that it will prevent any kind of abortion due to eliciting of this sign. Coming to the Palmer's sign, this can be shown well during the 4th to 8th week, and in this sign there is regular and rhythmic uterine contractions on bimanual palpations. And remember that on contraction of the uterus there is increased firmness of the uterus. On relaxation there is laxation of the uterus, and this laxation periods goes on increasing and increasing with the passage of the with the oldness of the pregnancy. That therefore it cannot be elicited so easily after 10th week of gestational age. And all these signs are called as the objective signs. They are called as what? They are called as objective signs and not subjective signs. Objective, because we have an objective over here, while the subjective signs were present naturally. While these objective signs have to be elicited by a person like a doctor, it should be elicited. That's the difference between objective and subjective. Coming to the immunological test for the diagnosis of pregnancy, first is the principle of this detection of the antigen, that is the HCG antigen in the maternal urine or the maternal serum with the reaction with the antibody, which is either it can be a monoclonal antibody or it can be a polyclonal as per the availability in the market. Coming to the test, there are three types of tests it can be divided into. That will be the immunological test as well as the biological test. In the immunological test, it can be divided as immunoassays without radioisotopes and with radioisotopes. Remember that the agglutination inhibition test, are also called as the Gravindex test, is the most commonly used method nowadays. And second will be the direct agglutination test, which is also called as the HCG direct test. And the next is the ELISA test, or the card ELISA test. And fluoroimmunoassays also are there. Immunoassays with radioisotopes include the radioimmunoassay as well as the IRMA, are also called as the immunoradiometric assay. And the other uses of this test are: it detects, first thing, it detects the pregnancy. Second thing it detects is about the ectopic pregnancy. And third thing, it can help in the monitoring of the IVF and ET. Also it can help in the follow-up cases of the hyatidiform mole, as well as in the choriocarcinoma and the hyatidiform mole. Okay, and then second thing is that there are some tests which were done earlier, also called as the classical test or biological test. These are the first discovered tests, like the Ascham's Zondex test. But these tests take more time, and they are not so simple, and they are not accurate, and they are costly compared to the immunological tests. So the immunological tests are preferred compared to the biological tests. So let us study about something about the test sensitivity, as well as when it will show a positive and when it cannot show the test as positive. That is, if it can give a false negative test, when it can give. Let us see that. Okay. So the first thing is about the agglutination inhibition test, which is the most important, also called as the Gravindex test. And this test sensitivity is 0.5 to 1 international units per ml, and direct latex test has 0.2 international units per ml, while two-side sandwich or membrane ELISA or card test has 30 to 50 milli international units, but the ELISA itself has 1 to 2 milli international units. And the IRMA and the radioimmunoassays have 0 microgram micro international units per milliliters of sensitivity. So as and as we go down, there is increasing sensitivity and more danger, because there is radioactive isotopes are used over here, which can cause damage to the fetus also. Coming to the next thing, that is when it can be detected. Usually it can be the Gravindex test can be performed 2 days after the missed period, while the direct HCG test can be performed after 2 to 3 days after missed period. On the first day of the missed period itself, you can perform the CAR test, or also called as membrane ELISA test, and you can perform the ELISA test 5 days before the first missed period itself. So it can, as and as we go down down the table, we find that we can detect it more fastly. It becomes more faster to detect as and as we go down the table. Remember that these test little bit this is faster, little bit slower, little bit slower, and finally it halts down to be the slowest. Okay, the slowest are the immunoassays. These are the middle, while these are the fastest ones. So let us write this up. So this as we go down, this becomes, the process becomes a slow one. As we go down here, the sensitivity increases, and as we go down over here, um, detection becomes faster as we go down. Two important procedures you need to know is about the Gravindex test as well as of that of the direct agglutination test. So the Gravindex test include the urine when it is which contains the HCG antigen when it is added with the HCG antiserum. So there will be neutralization of the antibody taking place. Now after this neutralization of the antibody, when it is added with the HCG coated latex, which is the antigen, now there will be no agglutination. So that's why this is called as the double agglutination test, or also called as the agglutination inhibition test, because inhibition of the agglutination shows that she is pregnant. But coming to this one, that is direct agglutination test, wherein we just take the HCG antigen of the urine. When it is added with the anti-HCG monoclonal antibodies, it directly gives agglutination, which confirms her to be pregnant woman.